So everybody is good? You can hear me well? You can see the PowerPoint? Yes? Great. So let's start it. So if you have any question, for sure, I will save the few minutes for questions. So let's first finish the recap. Please see that we didn't talk about amino acid or protein storage because proteins do not have storage form. They have an amino acid pool. Who gives to the pool? Naturally, the non-essential amino acid, because essential amino acid got to be supplied in the diet. Did we talk about nitrogen balance? Does protein intake equate nitrogen balance and also equate ammonia in your body? Are you aware of that connection? Yes. Secondly, try to understand that when you say nitrogen balance, it's all about protein. When protein intake is more than protein loss, then you are in positive nitrogen balance. Why do you need to understand nitrogen balance? Because finally, in a patient, you are going to assess urea levels, specifically blood urea nitrogen. So you are interested in knowing, and also in hyperammonemia patients, you want to restrict protein in diet. So you got to understand normal to understand abnormal. Protein intake leads to nitrogen and ammonia in your body. Then what did we do first? Protein digestion and absorption. Are both amino acid and peptides absorbed? Absolutely, yes. But then, since there are two enzymes, so what are the two enzymes that aid in digestion? Which, though both forms are absorbed, but which enzyme aid in digestion? uh, no, there are two classes, peptidases, proteases, but then they have their site. Some are of gastric origin, some are of intestinal origin. So do that in protein digestion and absorption. Do not forget yes, we don't talk about storage, but amino acid pool, but do not forget this big amino acid catabolism with nitrogen disposal first. So there are two, you do protein digestion first. There are peptidases and proteases. They have different site. Pay attention on that. Amino acid catabolism, first you got to understand nitrogen disposal or amino disposal. So when I am saying amino disposal, which is coming next, I'll ask you then. But here I was bringing your attention. There's proteases and peptidases. There are only two enzymes mainly. Then they are of different origin. So pancreatic proteases are renin and pepsin. Pancreatic proteases are renin and no, you can't flip-flop this list. Also, do you need entropeptidase for protein digestion? Absolutely. Sometimes you think, and what is its origin? Is it entropeptidase intestinal or gastric? Is it intestinal or gastric? So that also tells you that intestinal disorders can also lead to maldigestion. Not just that intestinal disorder leads to malabsorption. So since entropeptidase is a unique feature in protein digestion, not seen carb, not in lipid, so you got to understand that and what is its role. I'm bringing your attention to topics, points. Have you learned this? But I'm not teaching you. So yes, you know site absolutely, because pancreatic proteases are active where? In the gastric, stomach, or intestine? Where are pancreatic proteases active? In the intestine. In the intestine, small intestine, they are activated. So also, you got to understand the role of entropeptidases. Entropeptidases, which is an intestinal secretion. Bringing your points to focus. Please know that in my 50 minutes or maybe an hour of this review, I can only focus on key points. So when you ask me, should I do this, should I do that? Well, definitely. But I can only address some points which needs students struggle with or need more attention. So otherwise, you can do everything beyond this PowerPoint too. There is no, you can do this or not. But let's stay focused, right? Then did we talk tubular transport defect of amino acid and distinct cystinuria one versus Hartnup disease? We did it with protein digestion also, and trying to identify that there's also amino acid tubular transport for amino acid, not just intestinal. It's also at the level of kidney. So when you do these two disorders, what is common to them that you should do this differential? What is common to these two that you will do differential? Amino acid urea, very good answer. Amino acid in urine. So now you got to differentiate. Also, did I tell you to make the list of amino acid precursor of important compound in your body? Unless you knew that tryptophan forms niacin, would you even connect that tryptophan defect can lead to niacin deficiency? No. So you know normal, then you understand abnormal. Secondly, please know niacin is a vitamin B3. Dietary niacin deficiency leads to diarrhea, dermatitis, and dementia. Why am I saying that? Because you have not learned vitamins. So when you say pellagra, like at least you should know what is pellagra, which has not yet been introduced to you. Pellagra is 3D, diarrhea, dermatitis, dementia. Please do not flip this order. First you do transamination, deamination, urea cycle. Also, there are transport form of ammonia. Site is important. Can you release ammonia everywhere? No. Where do you mainly release ammonia? Liver, kidney, and intestine. So are there some reactions which are transamination versus some the deamination? Yes, there are some transamination, some deamination. For example, ALT. ALT releases ammonia. ALT and AST, do they release ammonia? No. So you got to first know the normal reactions, then bring them together, then do clinical. Or you do clinical and go back to the step. Only thing is, please do not forget to make the connection of normal with abnormal. Anyone thinking, okay, this is a clinical test, why not? But if you will just do hyperammonemia, you will miss protein digestion, amino acid being released, then they are absorbed, then they are catabolized. How do you dispose of amino group? What happens to the carbon skeleton? So if you just jump to urea cycle enzyme deficiency disorder, no, you got to go in the same order. I'm bringing uh, points of attention. Then when amino group is removed, what remains is a carbon skeleton. Is carbon skeleton a waste? Is this carbon skeleton? No. For example, so you got to understand why it's not a waste. If carbon skeleton converges into acetyl-CoA and derivatives, what will it form? If a carbon skeleton converging into acetyl-CoA and derivatives, it forms ketones. Are some amino acids ketogenic? Are some amino acids purely ketogenic? Which ones? Leucine and lysine. So they also have a group. It's not that phenylalanine is ketogenic. You get my point? Purely ketogenic is leucine and lysine. Yes, both leucine and lysine. So you're being specific there. You have a list of amino acids that do some work. You can flip-flop that list, right? Then let's do this later, which is inborn errors of metabolism will come here, and list of amino acid, what their precursor will come next, right? Definitely nitrogen disposal, urea. This is what I was asking you. There are specific amino acid, they are ketogenic. You don't say here any amino acid, purely ketogenic. You only talk about leucine and lysine. So why they have this fate is important for you to understand. You don't need to go to chat GPT, right? But you just get to ask yourself a relevant why. So this carbon skeleton is not a waste. But before that, the nitrogen disposal and ammonia, you got to understand that well, please. Right? Much well over protein digestion. Is this the first reaction? Why not? Is it reversible? Yes. Sorry. Which vitamin it needs? Is this transamination? B6. Is it accompanied by release of ammonia? No. And are their pair depends on what tissue they want to be formed? Yes, because it's a reversible reaction. But they have a pair. Alanine pairs with, what does alanine pair with? pyruvate, not with aspartate. So there's a particular pair. You learn transamination. You know they are reversible reaction. You know they require B6. ALT, AST are also marker of hepatic damage. Also, because you understand nitrogen disposal, is this also where nitrogen circulates? That nitrogen moves from muscle to liver and carbon moves from liver back to muscle. What is this known as? This is known as the glucose-alanine cycle, which is part of which pathway? Glucose-alanine cycle, or our cycle is part of which pathway? In your body, it's part of gluconeogenesis, providing glucose whenever body needs. Dr. Binstock has clearly explained that. Also, are you releasing ammonia or you are utilizing ammonia here? Are you utilizing ammonia here? Yes, so first you understand the reaction. But here you're releasing ammonia. Which one is reversible? The second one. The second one is reversible. Is it responsible for ammonia pool in the body? In the liver? Is this enzyme responsible for ammonia pool in the liver? And that's why NAG is an activator of urea cycle. NAG means N-acetyl glutamate. Whenever glutamate accumulates in your liver, it gives you a lot of ammonia. What that triggers? Urea synthesis. So yes, this is release of ammonia. You identify that. Is this reversible? Absolutely. So when you want to utilize ammonia, are you forming glutamate? When you want to use up ammonia, are you forming glutamate? Yes, but hyperammonemia patients, this goes too much backward. And that causes all the CNS signs and symptoms because if this too much backward, alpha ketoglutarate will be low. So yes, forming glutamate, you use up ammonia. So first you are understanding these reactions. So this is transamination, this is deamination. When you form glutamate, you use up ammonia, all right? But is transamination accompanied by release of ammonia anytime? Transamination is not accompanied by release of ammonia. That's why it's safe to do in most of the tissue. Then you got to bring all these reactions together and understand the key points, then do clinical significance. Does that make sense? So let's understand the key points that I address. Please, I hope are you following my pace? I just want to give you key points so you can then go back and you have a lot to do. You have physiology too, right? Are you following my pace? Is this working? Great. So yes, transamination, not released by ammonia, not really accompanied by ammonia. Glutamine, yes, can go to liver, kidney, intestine. Glutamine in the liver and glutamate results in ammonia pool, but still they are not the same reactions. So can glutamine go into the liver? Why not? Can glutamine and glutamate both give ammonia pool? Yes, but the enzyme working are different. Where do you see glutamate dehydrogenase? Top or bottom? Where do you see glutamate dehydrogenase? Top or bottom? Bottom. So there are different reactions. Then are some enzyme contributing to, just like some enzymes are contributing to ammonia pool, are some enzyme contributing to glutamate pool? Yes, there are certain reactions where glutamate is a common product. Where is glutamate a common product? Then you do deamination. So where is glutamate a common product? Which reactions you have learned glutamate is a common product? Transamination, right? Kidney glutamine giving ammonia is just for acidity, neutralizing acidity. Ammonia released in intestine, very safe. Intact portal circulation goes here. But what follows is urea cycle. You can draw the steps: 2 mitochondrial, 3 cytosolic, excreted through kidney in urine. But if you can't synthesize urea, why can you synthesize urea? Tell me 2 conditions where you cannot synthesize urea. When can you not synthesize urea? Are there any conditions? There is a urea cycle enzyme deficiency disorder, or When can you not synthesize urea? One answer is very good. I like the specific answer. Urea cycle enzyme deficiency disorder. Whether it is 1, 2, arginase, who cares then, right? Urea cycle enzyme deficiency disorder. But when you say when you can synthesize urea, hyperammonemia 1 and 2, so what do you mean by that? That means arginosuccinate synthase deficiency will synthesize urea? Arginosuccinate lyase deficiency will synthesize urea? So that's not a correct answer. Any urea cycle enzyme deficiency disorder will not synthesize urea. It's not just hyperammonemia 1 or 2. It could be arginosuccinate synthase deficiency. It could be arginosuccinate lyase deficiency. I like the answer urea cycle enzyme deficiency disorder. In general, BUN will be low, but not in kidney damage. Someone said that. Very good answer. If your liver is not healthy, then also you cannot synthesize urea. But if the kidney is not healthy, then you cannot excrete urea. Then blood urea nitrogen will be kidney damage, you cannot excrete urea. Then BUN will be high. So first understanding that what will happen when can I not synthesize urea? Then you jump to hyperammonemia, 1, 2, distinguishing. But if you miss one major first point, then the other differentials will not be complete. Then we talked about this nitrogen movement from muscle to liver, carbon back to muscle, right? Very good. Urea has two nitrogen. That's why, and also we are only interested in these two nitrogen. If you look back, urea has two nitrogen, and nitrogen is very dangerous. We got to understand where these nitrogen are being incorporated into urea. So you do the urea cycle, cytosolic mitochondrial, not under hormonal control. Absolutely not. We have discussed site. Now, when I say that kidney damage increases BUN. So is kidney a site of urea synthesis or is kidney for just excretion of urea? What is kidney for? Just excretion of urea. So you got to understand that site importance. Otherwise, you will not go long. When I was asking when will you not synthesize urea, somebody said kidney damage because you don't distinguish. If you know normal, you know abnormal. Kidney is not synthesizing urea. Kidney is only excreting urea. So kidney damage will not decrease BUN, will increase BUN. I'm not nagging here, but nag here is the activator along with arginine. Then you do hyperammonemia. All these line diagrams and these charts help you stay focused. But if you want to go back to the professor's slides, you can use it too. CPS1 and 2 are not the same enzyme, right? Is NAG activating CPS1 or CPS2? NAG activating CPS1, right? Very good. So you also, when there is exam stress, all the enzymes look similar. All right. Well, if you master your focus, they will not. Also, do questions at the end of the day if you have time, so that you can assess how well you are analyzing or testing the material, right? 1 or 2 mitochondrial, rest cytosolic. Hyperammonemia 1, first step. Hyperammonemia 2, second step. 3, aspartate enters. 4 is the 4 bicycle. 5th gives urea. So who will tell me if there is any urea cycle enzyme deficiency, what should be the cardinal findings in a patient? If any of the urea cycle enzyme deficiency is there, you will see high ammonia because you cannot detoxify ammonia. Your urea will be low, so your BUN will be low. What else? When ammonia backs up in the liver, how will it circulate up in the circulation? Too much ammonia. What will glutamine will be high. So see high ammonia, high glutamine, and low BUN. Don't say high alanine because ammonia circulates in major in the form of glutamine. Why would alanine be high? That's a wrong answer also helps you understand. So who will tell me when will alanine be high in circulation? What can go If alanine is high, what will happen? Tell me. That alanine will be high in the circulation. Skeletal muscle proteolysis. If there is too much skeletal muscle proteolysis, then alanine will be high. But otherwise, alanine should not be high. Ammonia is transported major as glutamine. So glutamine is high. Very good. Yes, you got to be specific there. So yes, this could be a common finding, then differentiate. So somebody was asking me that if you have this common finding, high ammonia, high glutamine, low BUN, so is it acquired? This means acquired, this means inherited? No. If it is high ammonia, high glutamine, and low BUN, your major focus is that you are not synthesizing urea. What can go wrong? Either urea cycle enzyme deficiency or there is a liver pathology. That's all. You're just trying to distinguish these two. These are less common, but they are also taught because they are part of your metabolism and nutrition. Hyperammonemia 1 and 2, if you have low BUN, tell me, is it differentiating? If you have low BUN, is hyperammonemia 1 and 2 differentiating? So I'm not teaching you here because no, it's common. So if you see low BUN, you can jump to any urea cycle enzyme deficiency disorder. But if I tell you, along with low BUN, there is high UMP or uracil, then what are you thinking? Then you're thinking hyperammonemia type 2. So there are some specific cardinal findings, but the key is still the same. Whatever is the defect, the substrate accumulate, products low. That will not change. Substrate can go into alternate pathway and form alternate products that may also increase. Uracil should not be high in a normal individual, but in hyperammonemia 2, uracil may be high. Does that make sense? How do you treat? What is your problem here? What is the problem in urea cycle enzyme deficiency disorder? What is high? What is high in urea cycle enzyme? Any urea cycle enzyme deficiency disorder? What is high? Ammonia? What else? What else? Glutamine. All you got to do is get rid of ammonia and get rid of glutamine from the body first. Then treat the defect. Then do enzyme replacement if it is available. Otherwise, you treat the symptoms. Carbon skeleton, so we did this. We identified transamination, deamination, what's happening in them, transport forms, and urea cycle. Sites, I told you, sites are specific. This can't be most of the tissue, no. This got to be liver, kidney, and intestine. Why? Can you release ammonia safely in liver, kidney, and intestine? Can you release ammonia? Yes, site is important. It's not that you're doing deamination in most of the tissue. So where are you doing what are you doing in most of the tissue? You don't do deamination in most of the tissue. So most of the tissue you can do transamination. Then why you can do transamination in most of the tissue? Because is it accompanied by release of ammonia? No, so it's safe. So you understand. First, you want to understand your relevant why. Once you do amino group, you have addressed all the point. I told you carbon skeleton, only the fate. Rather than saying, okay, what's happening to this amino acid? What are they converging into? That's a crazy list. All you need to understand are these four fate. Does that make sense? I asked you this too, that why leucine and lysine are ketogenic. So why are leucine and lysine ketogenic? Why are leucine and lysine ketogenic? Why are they ketogenic? Why specifically leucine and lysine are ketogenic? Anyone? Because they converge into acetyl-CoA and derivative. Acetyl-CoA can never form glucose. It can only form ketone bodies. So you understand the relevant why? And I told you, so you understand the term rather than memorizing these and amino acid, what are they converging into? And we don't waste your time there, right? We have done these two reactions. So who will tell me what is this pathway? We have reintroduced these two reactions in your renal module. What is this pathway? What is actually this pathway? No, what is this pathway that you have learned? It's a with propenyl-CoA, methylmalonyl-CoA, succinyl-CoA pathway, right? It's a propenyl-CoA, methylmalonyl-CoA, succinyl-CoA pathway. Yes, vomit converges into. I'm not saying what converges into. More specific question. Don't put your thought in the questions. Don't overread. Don't put your lines. Read the question stem as such. I'm just simply asking you, what is this pathway? This pathway is propenyl-CoA, methylmalonyl-CoA, succinyl-CoA pathway. Now tell me, in this pathway, do you need B6? In this propenyl-CoA, methylmalonyl-CoA, succinyl-CoA pathway, do you need B6? Yeah, vomit converges into it, but we are concentrating on vitamins. I told you, vitamins, drugs. Do you need B6 in it? So be mindful. Don't put B6 where it does not belong. Where does B6 belong then? B6 is not in methylmalonyl-CoA, propenyl-CoA, succinyl-CoA pathway. B6 belongs to transamination. So do that for me. Right enzyme, right pathway, right intermediate, right enzyme, right disease to the right pathway. We introduced this word. I asked you why it's ketogenic. We introduced that. Only non-essential amino acids can be synthesized in our body, but some amino acids become conditionally essential. We discussed arginine in our interactive session. Now comes this interconversion, inborn errors. To know inborn errors, students think, oh, let's memorize, let's cram hyperphenylanemia, alkaptonuria. No, first do the step. This is my step, this is its enzyme, this is its cofactor. Then come to amino acidopathies. So phenylalanine hydroxylase requires B6. What does phenylalanine hydroxylase require? What cofactor does it require? Phenylalanine hydroxylase. Now, when I'm saying phenylalanine hydroxylase requires what cofactor? You're saying PAH. PAH is the enzyme. Cofactor is tetrahydrobiopterin. So you don't flip-flop that. Then you will do classic, non-classic. First, you got to know, this is my enzyme, this is my substrate, this is my product. Does that make sense? Right? If you don't know, then you will flip-flop. So in phenylalanine hydroxylase, so tell me, phenylalanine hydroxylase or tetrahydro? First, you know the step, the enzyme, the cofactor, right? There's no B12 here, there's no B6 here, there's no folic acid here. Now tell me, phenylalanine hydroxylase or tetrahydrobiopterin defect? Where will phenylalanine levels be high? Phenylalanine hydroxylase or tetrahydrobiopterin defect? Where will phenylalanine levels be high? Now, when I'm saying that, somebody is saying classic PKU. Am I asking that question? No. I'm asking you then I'm simply asking you, in phenylalanine hydroxylase deficiency or tetrahydrobiopterin defect, where will phenylalanine levels be high? Excellent. You say both. Now, somebody said PAH defect. So this, I don't want you to go wrong at this point. So tell me, in PAH defect, you are saying phenylalanine levels be high. So what about tetrahydrobiopterin? If tetrahydrobiopterin is not available, can you metabolize phenylalanine? Somebody who's saying only PAH. Nope. Nope. I like the nope. You got to be nope. Nope means absolutely not. So both enzyme and cofactor defect have a common presentation. Then you do differential. So please don't say that in phenylalanine hydroxylase deficiency, only phenylalanine levels are high. In both PAH or tetrahydrobiopterin defect. Anywhere, step defect, substrate, accumulate. Product, low. You can't flip-flop that. Does that make sense? Important is to know the step, what is accumulating, what is depleting, is this the right vitamin? Then you differentiate. Tetrahydrobiopterin is not just required by phenylalanine hydroxylase, it's also used for catecholamine and serotonin synthesis. Then you know this normal function. That's why if you have a tetrahydrobiopterin defect, tell me, do you want to add additional treatment to this patient? When you have a tetrahydrobiopterin defect, Is restricting phenylalanine enough? If you have a no, what will you do? What will you supplement more? So if it's a enzyme, if it's a tetrahydrobiopterin defect, just restricting phenylalanine is not enough. Yes, you will give the cofactor now. Treatment will be different. Tetrahydrobiopterin. You will also supply the neurotransmitter precursor. So see, if you don't know normal, you will not understand treatment. If only when you know that tetrahydrobiopterin is required other than phenylalanine metabolism, then you will understand, okay, if this is a cofactor defect, I got to supplement the cofactor and the other neurotransmitter precursor, or this patient will not be treated. Does that make sense? Folate. Now, folate is essential for purine, pyrimidine, and methionine synthesis. If I ask you, which other vitamin do you want to put in here, which is also required for purine, pyrimidine, and methionine synthesis, what will be your answer? Is there any other vitamin which will also be in the same list of synthesis? Purine, pyrimidine, and methionine? B12. I like that answer. B12 will also be in this list, but indirectly, because B12 deficiency, is there anything wrong with folate? In B12 deficiency, is there anything wrong with folate? No, but in B12 deficiency, the folate is trapped. That is why both folate and B12, you will have all these syntheses affected. Does that make sense? B12 will indirectly affect them, and folate will directly affect their synthesis. But now you got to be mindful. Once I say that B12 and folate will affect their synthesis, don't put the wrong synthesis here. So is tetrahydrofolate and B12 required for homocysteine synthesis? I'm asking you a question. Is tetrahydrofolate and cobalamin required for homocysteine synthesis? Yes or no? No. But if I ask you, are folate and B12 required for homocysteine metabolism, to metabolize homocysteine? Then is it a yes? Then it is a yes. So what is being synthesized, what is being metabolized is different. Who is the substrate? Who is the product? Okay, big yes. I like the big yes. Okay. We got to save it for later in the life, right? So let's see. These are the two pathways, 1 and 2, right? So again, first understanding where is folate required. Is there any vitamin that can also affect its synthesis? Is this vitamin directly or indirectly affecting it? Because you got to understand why, a relevant why. This is very simple. If you want to distinguish one or from two, you clearly know the vitamin. Sorry. You clearly know the vitamin. You would not be confused. But if you want to distinguish only two, then that's a big confusion because two vitamins are required here. So in this, you got to do more differential, not just methionine levels. So low methionine will distinguish the step. Low methionine will distinguish that it is because of folate or B12. No, it cannot. So you put the right enzyme, right vitamin, and then you do differential. Now tell me, B6 deficiency, folate, and B12, what is common to all of them? What would be high in all of them? B6, B12, folic acid. All deficiencies. What would be high? Very good. I like the answer. Homocysteine. Homocysteine is high. So is that differentiating? No. So then you got to find the differential factor. Until you find the differential factor, you cannot understand the confirmatory diagnosis. You will always be lost. So try and narrow down. Narrow down very clearly. High homocysteine, I cannot jump to B6 deficiency. I cannot jump to B12, and I cannot jump to folate. Does that make sense? Right? Now, if I ask you one more question, low methionine, can you narrow down? High homocysteine, you cannot narrow down B6, B12, folic acid. But if I say high homocysteine and low methionine, can you narrow down to two of them? Which two? B12 and folate. Will you pick B6 deficiency as low methionine? No. So see, there's a big no, there's a big yes, yes. Then this was I was telling you multi-step, multivitamin pathway. And look at this. This is glucogen. Now you're not memorizing. Yes, vomit converge into them, but you're not memorizing that they are converging into succinyl-CoA. You know very well. If they converge into TCA cycle intermediate, other than acetyl-CoA, they can give you energy or glucose. So you are not memorizing all the amino acid, what they are converging, just understanding the fate. Why did she ask that it's ketogenic? Why is it ketogenic? Now, biotin deficiency will lead to low MMA, yes or no? Will biotin deficiency lead to low MMA? Will folic acid deficiency lead to low MMA? Will folic acid deficiency lead to low MMA? Yes or no? No, because that vitamin is not working here. You understand my point? Right? Biotin deficiency, clearly you can say that. Now, why SAM is there? Because students are confused with SAM. There are three methyl group carrier in your body: folate, B12, and SAM. Just that they don't work at the same place. So don't bring them to the same place. For example, will SAM defect decrease methionine? Will SAM defect decrease methionine synthesis? No, it won't. It doesn't work here. So SAM, which is not your next door neighbor, folate and B12 all carry methyl group, but they work at different places, right? So is melanin same as melatonin? Please know that I'm doing a comprehensive review, but is this space good? I will finish it in an hour, but maybe 5 more minutes. Is that okay? Is this helping? Great. So is melanin same as melatonin? I like the huge yes. Is melanin same as melatonin? No. So keep the melatonin is not same as melanin. Melatonin is synthesized from melatonin. Sleep wake tryptophan. I like who's ready, but you can be still ready. So yes, SAM is not synthesizing methionine, though it's a carrier of methyl group. SAM is not your next door neighbor. Here we are just analyzing which amino acids are precursor for which intermediates. For example, does glycine help in forming melanin? Does glycine help in forming melanin? No. Who helps in forming melanin? Tyrosine. So keep the right precursor and intermediate in the right pathway. So yes, glycine is not forming melanin. Melanin is formed by tyrosine. The tyrosine products are the products that are formed by tyrosine can also be metabolized by MAO and COMT. What we are learning here is first making a list of amino acid, what they form, and is there any clinical correlation in the list of in the amino acid list, whatever they are precursor for. For example, if tyrosine forms melanin, is there any clinical correlation? So first you make amino acid, list what they form, and are any one of them is clinically related. So if tyrosine form melanin, are there albinism? Just albinism? Anywhere else? Do you know tyrosine form melanin and it's clinically related? Tyrosinemia. No, see, now tyrosinemia type 1 is a wrong answer. I'm saying tyrosine and melanin. So melanin formation is clinically related. Albinism is the right answer, not tyrosinemia type 1. Is there anything else where you relate this? Anybody remembers PKU? In PKU, can you see hypopigmentation? Is that also related to low melanin? But that's not absence of melanin. That's just low melanin. So you see tyrosine forms melanin, then you relate it to albinism or you relate it to PKU. Does that make sense? You are making these lists and identifying, have I learned any clinical correlation here? Right list in the right pathway. Have you done Hartnupp's disease? Where have you learned Hartnupp's disease? What was Hartnupp's disease? What was a defect in? What was Hartnupp's disease? A defect in tubular transport or tubular absorption of amino acid. Have you learned serotonin and its relation in carcinoid tumor and depression? So you're making a list of amino acid and seeing what they form and are they clinically related. No, when I say, have you learned Hartnupp's disease? Yeah, yes. Amino acid tubular transport defect, absolutely correct. You're going right there. So then, where have you learned serotonin? In carcinoid tumor or depression? And now, histamine is formed by histidine, not phenylalanine, right? Do you understand that? So phenylalanine forms melanin, but does phenylalanine forms histamine? Who forms histamine? Histidine. So it is very, very specific. These are my amino acid and they form these products. Whatever products they form, then you see, are they clinically related? Does that make sense? The list is clearly given in red and blue, right? But all I'm saying is it has been clearly identified in your question stem. For example, creatine. Tell me creatine, what are you thinking? Which amino acid? I'm just throwing it just like that. It's not that, oh my God, you're glycine. Anything else? Anything else? Arginine too. Yes, glycine, arginine. So see, you just throw it. Okay, where have I learned that? Where have I learned melanin formation, melatonin formation? So you understand this list? I like that. Yes, creatine is glycine, arginine, and methionine, I think, if I'm not wrong. Everybody has answered all of them. Just I'm bringing to your attention. That doesn't mean you just keep cramming creatine. Make the full list, right? Yes, you relate creatine mainly with glycine, arginine, and methionine. Absolutely wonderful. So there's a list of amino acid one they form. Now amino acidopathies. I explained you how you do that. Amino acidopathies. Please, again, I am not teaching you reteaching you. Draw the steps. Know the vitamins. Know the enzymes. Understand that B6 deficiency can clearly differentiate 1 and 2, but folate and B12 cannot be differentiated just from step 2 defect, right? Then cobalamin is used for homocysteine metabolism. What else cobalamin metabolizes apart from homocysteine? What else cobalamin metabolizes apart from homocysteine? What is it? Methyl malonic acid or methyl malonyl CoA, which is the next step. Some common finding, high homocysteine, that is not differentiating B6, B12 from folic acid. Then you see what is differentiating. Does that make sense? Are these both required? Are both folate and B12 required for methionine synthesis? Yes, but B12 deficiency leads to folate trap. Sorry, they are in the same order. They are always done. B12 deficiency leads to folate trap. That's why both B12 and folic acid deficiency, you have macrocytic and megaloblastic anemia. B12, this is what I asked you. B12 is metabolizes homocysteine. B12 also metabolizes methylmalonyl CoA. So you got to keep the right enzyme, right vitamin, so that you know if I'm asking biotin defect, what will happen to succinyl CoA here? Oh, sorry. If I'm asking biotin defect, what will happen to propionyl CoA here? High or low? Biotin defect. It is high. If you don't know the step, you don't know the step and the enzyme and the vitamin, you will flip-flop what is high, what is low. So B6, B12 folic acid deficiency, high homocysteine is not differentiating. It's common to them. Do the differential, right? When we talk about leucine and lysine, sorry, yeah, high propionate. When you talk about leucine and lysine, we identified them as what type of amino acid we identified them? Leucine and lysine. Ketogenic, right? So each one of them have a specific group. Does that make sense? Branch chain branch chain amino acids are metabolized by skeletal muscle for need. What vitamin is essential for them? What vitamin is also essential for metabolizing branch chain keto acid, which is maple syrup urine disease deficiency? What vitamin? What vitamin is here in branch chain keto acid dehydrogenase? Not B6. It's the same TLC fun. No, not biotin. Thymine, no B12. To metabolize branch chain keto acid, TLC fun. It's same as PDH, thymine dependent. This is thymine, very good. Somebody said thymine, I like that answer. Branch chain keto acids are metabolized. And when they are metabolized, they don't need B12, they don't need B6, they need thymine. They are thymine dependent, yes, and multiple vitamin dependent, right? So we have learned these amino acidopathies. Did you learn classic from non-classic, which is more severe? Which is enzyme deficiency, classic or non-classic? Which is classic, more severe with variety of symptoms, whether musty or mousy odor or hypopigmentation. Do you need to supplement tetrahydrobiopterin in classic PKU? Do you need to supplement tetrahydrobiopterin? No. You need to understand that. Why would you supplement a tetrahydrobiopterin in classic PKU? In non-classic, yes, you want to supplement tetrahydrobiopterin and some neurotransmitter precursor, but not in classic, right? Does that make sense? So which is classic, top or bottom? Which is classic, top or bottom? The top is classic, very severe. Clinical manifestation I've clearly explained. Non-classic, mild cofactor defect. Now, if you, again, I'm just being, is this helping? Just bringing to your attention again, look at this. Sometimes students ask me, how do I do tyrosine? You will be successful if you don't mix them up. Your phenylalanine metabolism just stops here. Your phenylalanine metabolism is phenylalanine tyrosine, then starts tyrosine metabolism. Tyrosine metabolism is either it's metabolized, where you learn alkaptonuria and tyrosinemia type 1, and it forms specialized products where it's precursors. So there are two things that happen to these amino acid. But phenylalanine metabolism should stop here, please. They just draw it to connect so you can know signs and symptoms. Does that make sense? Tyrosine metabolism is separate. So if I ask you, this is also important, you need to know which amino acid metabolism is which disorder. If I ask you albinism, is what disorder? What would you say? Which amino acid disorder is albinism? Phenylalanine or tyrosine? Tyrosine. So don't make that mistake. PKU is phenylalanine disorder. Albinism is tyrosine disorder. Alkaptonuria is? Again, alkaptonuria is which amino acid disorder? You got to be mindful. Which right amino acid, right intermediate, right enzyme, right deficiency. Alkaptonuria is also tyrosine disorder. Does that make sense? And they have peculiar findings too. When you see CNS changes, where are you going? Are you going towards albinism? Does albinism have CNS changes? No, it is classic PKU. Why I would say classic PKU or phenylalanine hydroxide? Because it's more severe. Very good. Again, this is also trying to understand where is the disorder. I told you tyrosine disorder, you will relate to albinism, alkaptonuria, tyrosinemia type 1. But then look at this. If you don't know the step, it's just to bring your attention, doesn't mean that you will start harping on succinyl acetone when you go back. I'm just doing this so you can understand how you should assess whether you know renal module or not. Tyrosinemia type 1 or alkaptonuria, which deficiency succinyl acetone will accumulate? Alkaptonuria here or tyrosinemia type 1? Tyrosinemia type 1. So you got to understand that intermediates above the block accumulate, behind the block are low. Does that make sense? If you know the steps, you will understand who's accumulating and who's depleting. right? You have done this pathway, right enzyme, right vitamin. When they are defective, substrate will accumulate, products will be depleted. Does that make sense? Now, though Dr. Panini has clearly identified MMA1 versus MMA2, but please see, because he has identified inherited defect. But if you are generally thinking cobalamin, so if I ask you, there's a cobalamin deficiency. We are not saying MMA1, MMA2. What synthesis will be reduced? If there's a cobalamin deficiency in a body, what synthesis will be low? I'm not saying methyl, adenosine, methionine, what else? Succinyl-CoA, very good. So you know the right step and the right vitamin. Does that make sense? Also, please see, some people are confused between folate and B12 deficiency. Folate B12 deficiency commonly present as macrocytic megaloblastic anemia. But as I told you, in folate and B12 deficiency, in folic acid deficiency and B12 deficiency, will methionine levels be low? In both of them. Yes, but in folic acid deficiency, will MMA levels be low? No, because you will not make that mistake if you know the right step, right vitamin, and identifying them. Now, Dr. Panini has distinguished one from two, MMA1, these are inherited disorder, where specific form of cobalamin is missing. That is different. But otherwise, cobalamin deficiency, please be mindful, can affect any step, any synthesis, wherever it is used. For purine and pyrimidine, please first identify adenine, guanine, hypoxanthine, xanthine, where you see them, right? Not that you draw these diagrams. If I want to synthesize adenine, what do I need? Which group I need? What group I need to add if I want to synthesize adenine? Amino group. Amino group donor is glutamine. Where have you seen these hypoxanthine, xanthine? Do you know purine synthesis, purine salvage, or purine catabolism? These minor bases. Purine catabolism, don't put them in de novo synthesis, right? They're products, they are formed as a product in purine catabolism. Xanthine oxidase, where will you see put xanthine oxidase enzyme in? Purine de novo synthesis, purine salvage, or catabolism? Xanthine oxidase, purine catabolism, right enzyme, right intermediate, right rate limiting enzyme, right disease in the right step. So that's why you should know hypoxanthine, xanthine, adenine, guanine. Now look at this. Thymidine synthesis requires what group? What group would you need? So you're not drawing them, you're recognizing them. Methyl group. Now, what are your methyl group? Who can come in here? Who all are your methyl group donors? Sam, what else? Sam, just Sam? Is just Sam adding methyl? Cobalamin and folic acid. Who works here? Is Sam forming thymidine? Only folic acid is forming thymine. Once you know that, now methotrexate intake can affect thymidine synthesis. Methotrexate intake can affect thymidine synthesis. Yes, by reducing the availability of folate. So see how much normal helps you know abnormal. First, you know that thymidine synthesis require methyl group. Then you brainstorm methyl group donor are SAM, folate, B12. B12 is not working here. Folate is working here. Methotrexate intake then can reduce my thymidine synthesis. But now if I ask you, can B12 defect also reduce thymidine synthesis? Can B12 defect indirectly can also reduce thymidine synthesis? B12. Why? Because of B12 is not needed for folate. No, you would not say that. Folic acid is independent. B12 is released. Very good. B12 is essential to relieve the folate trap. Absolutely. In B12 deficiency, you will see folate trap, and this can be affected. So just bringing your attention to, okay, this is my group. Now, will CTP synthesis require folate? Will CTP synthesis require folate? Tetrahydrofolate region. I'll get to the questions later. Will CTP synthesis require folate? No. So see where folate will work. Folate will work where you need one carbon group. Now, one carbon group can be methyl. That's why there could be a lot of one methyl group donors, SAM, cobalamin, folate. Then you see where they are working. So do you need SAM for methionine synthesis? Do you need SAM for methionine synthesis? No. So will SAM defect lead to low methionine? No. So what do you need for methionine synthesis? Who comes as methyl group donor? Methylcobalamin and cobalamin and folate. So cobalamin and folic acid deficiency, you will see low methionine. So you got to understand who is doing what. Does that make sense? But in though folic acid is directly required for all these syntheses, but will B12 defect or B12 deficiency also reduce their synthesis? All of them? Will B12 defect also reduce? Yes, because B12 deficiency leads to folate trap. Does that make sense? So macrocytic and megaloblastic anemia can be seen in all of them. So tell me, megaloblastic anemia due to in UMP synthase deficiency is because of why there is megaloblastic anemia and UMP synthase deficiency? Because there is no UMP. So there is not DNA because there is no UMP and there is no thymidine nucleotides, right? No DNA means there is no ribonucleotide reductase. But yes, when you say nuclear maturation lagging behind cytoplasmic maturation, that is the cause of low nucleic acid synthesis. But what I'm asking you, why you in UMP synthase deficiency, you have macrocytic anemia because there is no UMP, so there are no pyrimidine nucleotides. That is why nuclear maturation lags behind cytoplasmic maturation. Or there is slow DNA synthesis. No, your DNA synthesis answer is absolutely right, but due to what? Because of low pyrimidines. Does that make sense? Yes. UMP synthase leads to orotate buildup. I'll keep the question answers to the end. But so in cobalamin deficiency and folic acid deficiency, both you will see low methionine, low purines, low pyrimidines. But then how will you differentiate? In both folate and B12, you will see low methionine and low methionine in both folate and B12, then you got to differentiate. I think I lost my track. So please see that let me finish this so our students can leave. Then you can ask your question because I'm losing track of finishing in the chats when I see the questions in the chat. Can I finish this? So let me finish my flow. There are a few slides left. Is that okay? We will get to the questions once I finish. Okay, great. So let's go back. Let me just quickly finish this. So folic acid deficiency, B12 deficiency, and UMP synthase deficiency all lead to megaloblastic anemia. But ask yourself, irrelevant, why and how you can distinguish. That's why I asked you in UMP synthase deficiency, why will you see megaloblastic anemia due to low UMP and low pyrimidine nucleotide and low DNA synthesis, and so nuclear maturation lag behind cytoplasmic maturation. So B12 and folate both are required for methionine synthesis. Folic acid and B12 deficiency, methionine will be low, but then you got to differentiate. Whether folate or B12, you are not doing purine pyrimidine, whether folate or B12, folate directly you're not doing. B12, you have a folate trap. So in both of them, you will see macrocytic anemia. Now look at this. So is B12 required here? Is B12 required in thymidine synthesis? What do you directly require in thymidine synthesis? What do you require? Folate. Folate is required. So does methotrexate intake reduce thymidine synthesis indirectly? Does methotrexate intake reduce thymidine synthesis? Then you bring your drugs. So yes, thymidine synthesis requires folate, not B12. But wherever But in B12 deficiency, when folate is not available, this step could be affected. But directly, this step only will be affected when there is no folic acid or methotrexate. Is methotrexate an anti-cancer drug? So bring in your drugs. All anti-cancer drug acts on folate, purine, and pyrimidine because you want to get rid of the cancer cells. That's why they act there. Ribo into deoxyribo, you required a reductase. Why? See, it's important to know the natural inhibitors along with the artificial. Remember, this natural inhibitor was accumulating in ADA deficiency, affecting both T and B cell, right? For nucleotide synthesis, do you need base, sugar, as well as phosphate? Yes. Always sugar and phosphate are added in the form of PRPP. And what's the enzyme to add PRPP? Base and sugar are always added in the form of PRPP, and the enzyme to add PRPP to add only PRPP is known as ribosyl transferase. No. PRPP synthetase is not to add PRPP to a step. PRPP synthetase is to form PRPP. To add PRPP, you need a ribosyl transferase. Very good. Somebody has identified the ribosyl transferase correctly at GPRT, APRT. Then you do clinical condition. I told you do both purine and pyrimidine synthesis as well as catabolism. Do not do pyrimidine catabolism because water-soluble product. Compare purine with pyrimidine synthesis, regulator, rate-limiting enzyme, activators, as well as inhibitor. Hyperuricemia leads to gout. Can you name some drugs to treat hyperuricemia? If you want to reduce uric acid levels, allopurinol. Colchicine is not to reduce uric acid levels. Colchicine causes microtubule arrest. Febuxostat, very good. Colchicine is used to reduce inflammation. I'm asking to reduce uric acid levels. So your answer is allopurinol and febuxostat. But colchicine is for inflammation, right? Always do compare synthesis. So de novo purine or pyrimidine synthesis. The mechanism of action. Yeah, that will tell you. The site of action will tell you then where they are acting. But I asked you hypouricemic drug, your answer should be allopurinol, febuxostat, not colchicine, not non-steroidal anti-inflammatory drugs, not steroids. Steroids is reducing inflammation. So do you understand my point? So first you compare de novo purine and pyrimidine synthesis. So PRPP synthetase is rate limiting for de novo purine or pyrimidine synthesis. PRPP synthetase is rate limiting for de novo purine or pyrimidine synthesis. PRPP synthetase is rate limiting for de novo purine or pyrimidine synthesis. Neither one of them. Neither one of them. It's not a rate limiting step. Very good. It's a regulated step. So what's the rate limiting step? Should be clear. For de novo purines and PRPP synthetase is rate limiting in neither of one of the step. It is the PRPP amidotransferase. So keep the right enzyme, right pathway, right regulation. First do synthesis, then do catabolism. Catabolism releases the bases to do salvage. So if I ask you salvage, if I ask you purine catabolism enzyme, is it HGPRT? Is HGPRT a purine catabolism enzyme? Yes or no? Is HGPRT a purine catabolism enzyme? No. So every enzyme has every pathway has a specific enzyme. Purine catabolism is your xanthine oxidase, adenosine deaminase, right? De novo synthesis, PRPP synthetase, PRPP amidotransferase, then their regulation, right? Remember, they first activate the sugar and then they build the ring. They have feedback inhibitors and activator. Who's the universal turn on for purine, pyrimidine, synthesis, de novo, or salvage? PRPP, right? So are they, so they are also anti-cancer drugs, right? Have they been introduced in the lecture? Are they affecting purine or pyrimidine synthesis? These anti-cancer drugs are affecting purine or pyrimidine synthesis. Purine synthesis, not pyrimidine. So the site of action, which somebody was asking me, their mechanism of action or site of action is specific. So it was PRP, is PRPP synthetase rate limiting? No. Is it regulated? Yes. Is PRPP aminotransferase rate limiting? Absolutely. We have identified their regulators. After you do synthesis, do catabolism because they release the bases that go into salvage pathway. Catabolism releases the bases that go into salvage pathway. Adenosine deaminase, xanthine oxidase, you have done in purine catabolism. So first you catabolize, release the bases, and then go salvage. In HPRT deficiency, will you see hyperuricemia? Will you see hyperuricemia in HPRT deficiency? Will you see hyperuricemia in HPRT deficiency? Why? Because number one, they form a lot of uric acid. Secondly, the PRPP is low and the PRPP is high and IMP GMP are low. So what high PRPP and low IMP GMP turns on which enzyme? High PRPP and low IMP and GMP turns on which enzyme? Purine de novo synthesis, but which enzyme? PRPP aminotransferase. So enzymes have specific regulators, specific activators, specific inhibitor. So is AMP, IMP, and GMP, is IMP and GMP inhibiting CPS2? Are IMP, GMP inhibiting CPS2? No, so there are specific regulator. So that is why you should know the specific rate limiting enzymes, specific regulators. So why Leishman patients have hyperuricemia? Because PRPP aminotransferase is turned on big time in them. Does that make sense? So we are trying to identify the right enzyme, right rate limiting step, right regulators. IMP, GMP are not are not acting on CPS2, right? Does that make sense? So did we identify that Leishman patients have hyperuricemia? Yes, absolutely. Also ADA deficiency. Look at this ADA deficiency. Do they have loss of both T and B cell immunity because of what accumulation? Deoxy ATP. So do you identify ADA deficiency as loss of both T and B cell immunity? Yes, yes, because what accumulates in them is deoxy ATP, which is a natural inhibitor of RR, right? What is RR doing? If I ask you, for example, if I ask you what is PRPP aminotransferase, you said rate limiting enzyme for de novo purine synthesis. What is RR doing? What does ribonucleotide reductase do? Form deoxynucleotide. Again, pyrimidine ring, they first go for the ring, activate the sugar. Is UMP synthase deficiency, you build up orotic acid? Do you build up orotic acid in UMP synthase deficiency? Yes. Yes. So this is pyrimidine synthesis. And look at this. Is folate required for thymidine synthesis? Is folate required for thymidine synthesis? And it can methotrexate indirectly inhibit thymidine synthesis? Yes. So this is a good slide that is bringing your rate limiting enzyme, activators, inhibitors, drugs, and where they are acting. Does that make sense? Right? So then you are going to this UMP synthase deficiency. So if you see high ammonia in orotic acid, will you pick UMP synthase deficiency? If you see high ammonia and high orotic acid, will you pick UMP synthase deficiency? No. High ammonia will never be seen in UMP synthase deficiency. There is nothing wrong with urea cycle here. But what is UMP synthase? That synthesizes UMP, right? UMP synthase deficiency, do you see both? So high ammonia and high orotic acid, you will not pick UMP synthase deficiency, right? If it is high ammonia and high orotic acid, what will you pick then? OTC deficiency, very good. But if you see low uracil, and high orotic acid, will you pick OTC deficiency? If you see low uracil and high orotic acid, will you pick OTC deficiency? No, that is UMP synthase deficiency. So you got to brainstorm what is accumulating, what is depleting. Does uridine help in UMP synthase deficiency? Because of two reasons. One, it bypass the step and supplies all the nucleotide, relieving megaloblastic anemia. Secondly, it also inhibits this rate limiting enzyme, reducing orotic acid formation. So one thing I want to tell you before you leave, I think this is my last two slides. Please, in an enzyme deficiency step, just definitely concentrate on restricting substrate, supplementing product. But one more treatment is, just a second, please. Sorry, my battery was low. Even my battery is low. Just joking. Not just restricting substrate, supplementing product, but also inhibiting rate limiting enzyme is also one of the treatment of enzyme deficiency. Don't forget that. Orotate is orotic acid, absolutely. So this is what I asked you. If you have high ammonia and high orotic acid, will you pick UMP synthase deficiency? No, this is a big no-no. But if you see low uracil and high orotic acid, then you will pick UMP synthase deficiency. Why not? You will do that. Does that make sense? Good luck.